And I think one of the great things that I've thought about this afternoon is it shows that there is no shortage of creative ideas, right? Tremendous ideas. The bigger challenge is how do we implement all these tremendous ideas with the challenges in healthcare today? And what that requires is excellence and leadership. And that gets back to the entire mission of the National Center for Healthcare Leadership. We strongly believe that excellence and leadership will result in better healthcare and better, healthier communities. So that's what all these ideas are about. We have this wonderful expert panel here, and I've got some questions for them, but I hope that you will think of some questions too that will provoke good discussion here, because I think some of the discussion and questions have been great dialogue as well. So what I'd like to do is start out by asking each of you panelists, what one thing did you hear this afternoon that just really popped for you? You thought it was just very interesting, creative, and also maybe add some creative project that you're working on that you think will really accelerate improvement of the health of the communities. George, I'll start with you.
I thought the entire afternoon was terrific, actually, all of the speakers, and very thought-provoking for me. If I had to pick one thing, I think it might be the sort of the health 1.0, health 2.0 sort of transition, and the discussion of technology in terms of enabling, you know, how people will relate in a patient-centered way to the folks that are providing them, and the new potential entrants into that market. And that's all, in my mind, in the healthcare space, not in the health space yet. And I thought the panel in the afternoon, these last two speakers, really raised the issue of the breadth of what healthcare organizations can do. So in terms of innovation, or what one thing, I don't know if I can keep it to one, but one, in 2008, HealthPartners embarked upon a course of developing an internet care delivery model, which is Virtuel, which we then launched in 2010, and which is now approaching 5 years of experience. And it provides care for 50 diagnoses over the internet, supported by nurse practitioners, is tightly linked to our own care delivery system of clinics and hospitals, and yet now has far beyond that reach. You know, it was described as a Health 2.0, and it took that presentation for me to think about it as an innovation, because it's already 6 years old in my mind. So that's the first surprise, is that there's asynchronous sort of movement of the healthcare industry in this direction. And then secondly, along that same pathway, we are now thinking about something beyond Health 2.0 in terms of how to measure health for those people that we deliver care for, in terms of some public health type of measures, in terms of length of life, years of life lost, and so forth, but also in terms of some non-traditional measures such as wellness and so forth. The key to that innovation is the ability to personalize the broader social determinants of question issue to the population for which our healthcare delivery system has responsibility, and therefore to begin to access value creation for that 80% of those factors beyond healthcare delivery, which takes up that 17 point whatever percent of GDP. I don't think healthcare executives are thinking, a lot of them are thinking like that. Maybe they are, but I think that's the innovation we're working on now.
The changes in leadership that will have to occur because of that are significant.
I certainly felt that all of the comments about leadership were right on target from every single one of the speakers. And the comment, the quote by Risa, the president of RWJ, in terms of wondering whether the healthcare industry and so forth would soon be merged, I think was right on target. And I'm not so sure that people will achieve that sort of existence in the next round of healthcare if they don't envision themselves as something different than hospitals and clinics.
Right.
or doctors and hospital administrators. So I think that's going to be a huge leadership mental model challenge, and it's primarily a challenge for the people in this room and the people in rooms like this around the country.
That's right. Bruce, anything that really struck you this afternoon? And also, of course, we want to hear what innovations you're leading at America's Essential Hospitals.
So the idea of the quarterback struck me because I see so many communities and health systems, grappling with the issue of population health, wanting to do something, and not knowing where to start, and also not having a replicable model they can take to scale and borrow from somewhere else. So I thought that was something that was doable and gave people sort of a starting point, a nidus around which they could organize their efforts. When I think about innovation, I'll think about what we see around the country among some of our member essential hospitals. And I'd go to the Twin Cities, actually, which you know well and was referenced earlier. Hennepin Health was formed, which is essentially a Medicaid ACO. It is a Medicaid ACO, actually, in Minneapolis and the surrounding counties, where the hospitals, the social service agencies, Medicaid, and others have enrolled about 9,000 childless adults, high users of the health system, lots of behavioral health issues, lots of addiction issues, and costs off the chart. And what they've done through better care management, through better counseling around addictions and other issues, and better medical management, is actually drop their use. That sounds nice, and we've seen other models like that, but the critical thing is they're actually taking the savings and under their model, reinvesting them in things like secure housing for these patients. So we always talk about affecting the social determinants, but here's a case where the health care system is actually taking dollars it itself is savings through better management of very sick people, and now investing that and changing the trajectory. We don't see that too often yet, and I think that's a model we're going to be seeing hopefully more of in the years to come.
What do you think it is that's so challenging to replicate projects like that? Because you see programs like this, we've heard some this afternoon, with outcomes that are very exciting and positive, and yet what's the challenge there in replicating that and making it really gain some momentum?
Well, I would say two things. I mean, first of all, you do have an alignment in Minnesota, perhaps better than other places, an idea that collaboration and social capital are more important. I'll be frank, I worked in Florida for years. I don't think this would happen in most large communities in Florida. You see that level of collaboration, that culture of collaboration. And some of this may actually go to John's question about some of the regional differences we see in our country driven by historical differences. But I also think it was a realization that around leadership, around the idea that this could not fundamentally change unless those investments were made. So we're seeing those nice graphs about how so little of what we can affect will really be affected by the healthcare system traditionally. But I don't think enough of us have really taken that leap into knowing what that looks like. You had that alignment, you had that leadership in the Twin Cities, and now you see the difference.
Great. Bechara, you're in a challenging community here in Chicago. What examples of innovation are you leading that you've seen effective, and maybe anything that jumped out at you today that might be helpful?
Well, first of all, welcome to everybody who's not from Chicago. Welcome to the city. For many years now, when people ask me, why are you in public health and what excites you about public health? And my answer has been there are two areas in public health that are extremely exciting right now, and they're really hot, and there's tons of potential for innovation in there. And that's the intersection between public health and the healthcare system, and the intersection between public health and economic development. So to be here at a session where that's really the main focus of the session was definitely a great, great environment for me. Here in Chicago, as a Department of Public Health, and we have one of the largest and oldest Department of Public Health in the country, and we focus a lot on policy, systems, environmental changes, in addition to being involved in the delivery, on the delivery side. But over the last couple of years, we've been focusing as to how can we take those areas of intersection and make a difference? So one example that we've worked on for the last few months have been with Presence Health, and this will be a formal announcement will be coming tomorrow, but I think there's a lot of conversation about community benefits. So one of the areas that we've been working on is how can we re-engineer together with Presence Health, one of the largest healthcare delivery system here in Illinois, a a lot of funding that could potentially make a difference on population health. So we've been working with Sandra Bruce and her team for the last few months on trying to figure out how we can do that. And we're looking at areas like clinical interface, looking at making sure that high-risk pregnant women, when they interface with one of the Presence Health providers, can we interface them directly with one of our case management teams? So we have our nurses go and do home visits and that type of intervention. So a lot of focus on clinical health, but also we're looking at the built environment. How can we work to making sure that our city is more, has more friendly environment for biking, has better environment for food access. So those types of interventions that the healthcare system has not traditionally invested in, this is something that Presence Health with us, we're working together on making a difference. So that type of private-public partnership, I think, has a lot of potential for innovation, and we're really excited about that. But we also think about other types of intervention. In public health, I know you've asked about the lead poisoning and lead exposure. So we treat every year, we monitor every year over 1,000 kids in Chicago who develop lead toxicity. And guess what we do? We wait until we get a lab result from Quest or LabCorp to tell us this kid has lead toxicity, and then we invest tens of thousands of dollars to provide services for this kid, to fixing their homes, let alone all the potential damage and neurological damage that kid would have endured. So we asked ourselves, is there a way for us to predict who are these 1,000 kids who are going to have lead toxicity and not really wait until they have lead toxicity? So we've worked with data science for social good out of the University of Chicago, and it helped us develop a predictive analytics tool that would allow us to predict who these 1,000 kids are before they even actually get that lead poisoning. So we can invest our resources more effectively in making sure that we're sending our inspectors, we're fixing their homes before these kids end up developing lead toxicity. So these types of innovation, these types of interfaces between the public health system and the healthcare delivery system have huge potential. And I'm really excited that we're here in Chicago, that we're really trying to write that chapter, and we would like to learn more about from others as what else can we do.
That's great. And earlier we talked about collective impact, that it really takes partnerships and a focus on goals. So how often or what is the frequency, do you think, of public health collaboration with health systems? Do you know across the country? Do you think there's a lot of that? I'm sure we need a lot more.
Yeah, I think we need a lot more. And it'll be interesting here, just by a show of hand, how many of you here know or have met with their local health officer? Just not many. I mean, that's to me an example as to why, these health departments are there. We have tons of resources. We're here. We want to make a difference. So, we want to make sure that we're creating those connections.
Right. That speaks to the fragmentation of our health system. And if nothing else, during this age of, needing to change for a lot of reasons, if it pushes us towards that collaboration, that'll be great. So we're going to look for even more good things from you in Chicago. So Don, what struck you this afternoon? And tell us a little bit about the innovations at KentuckyOne.
What was going through my mind was wondering if it's really going to happen. Because we've talked about this for decades. These same kinds of market forces happened in the 80s and the 90s before, but it hasn't pushed the healthcare delivery industry to really dramatically change. We still have huge variation across any geography that you want to pick. So I'm wondering if this new technology this time is really going to accelerate the knowledge transfer and the comparison, and if the market, if the consumers, the buyers of healthcare are really going to make changes in benefit and contract programs to let patients go to another state or another community to receive care because it's better. If it does, we'll have dramatic improvement because we've got such a large opportunity there. What also struck me about the leadership part of it is I don't know if the healthcare leaders who are leading healthcare delivery systems, many in this room very, very good, are prepared to do the population management part. And if anything, their boards and their leadership team may need to recognize that they need somebody else to help them with that other foot in the other canoe. because we can talk about collaborating with public health. And in Kentucky, we're one of the most needy states in the whole country as far as improvements. And I think a lot of people were surprised at how many people got coverage this past year through the exchanges. Almost 500,000 people. Out of 4 million people in the state, we're now over 1 million people on Medicaid right now. We're on the panels, the councils with the governor and with the mayor of Louisville. Healthcare improvement is a top priority for them across their annual plans. So we're working with them. Actually, the health officer from Louisville is actually on one of our quality board committee. So we're very much working with them. But what I think is going to happen is, if the market shifts and really demands that you've got to perform at a high level, not only will the provider organization need to get to the top quartile, they'll have to get to the top decile for quality, safety, service costs, service and the integration being a key part of it. But what I think will really happen if this happens is the standard deviation between those quartiles or deciles is going to shrink. So the margin of error or variance in our delivery is going to get really, really, really small. And the sloppy providers literally aren't going to be tolerated. I hope that's what happens.
Mm-hmm. So you bring up a good point, being a practical person. There are barriers, definitely. And earlier we heard about incumbent challenges. You mentioned a little bit about some of the barriers, maybe the mindset's not there with the leadership. How do we overcome those? What are some of your recommendations? How do we really accelerate these changes?
I keep going back to the market. Is the market asking us to do this? And if so, we will change with the market. What we've been delivering in healthcare, what we've been delivering as payer organizations or public health organizations, we've met the challenges of what the market's asked. And it's been okay with what we've been delivering so far. I think, given the metrics somebody was just mentioning before about how many workers per covered life, as the demand gets tighter, I think the market will shift and raise the expectations on us. I'm confident that the industry will adapt to it. Mm-hmm. We have to.
Right. George, you have thoughts on that? How can we overcome these barriers?
Well, actually, I think I really like your question about will it happen? You know, what's the pathway to it? I wonder how many systems in the room are measuring their quality and performance data by race, ethnicity, socioeconomic status. A show of hands? So a few, and that's what I expected. That is a commitment we made in 2003, and it took us 5 years to get to the point where we had 96% of our enrolled population. And now cutting that by screening for the usual screening conditions, preventive screening conditions like breast cancer screening, for chronic disease management using the traditional diabetes and cardiovascular disease measures. We have gaps in terms of performance. All the lines are moving up, which is encouraging, but the gaps remain, particularly in the outpatient setting. And to the extent that current performance for systems begins to approach that asymptote and the systems bunch and millions of dollars in incentives get applied by public and private systems, you need other ways to get there in terms of improving your performance. One that we found is by tailoring care to subgroups by race, ethnicity, culture, language preference in particular. And so I began to see an inkling of incentive structures leading health systems to begin to think about access to care, transportation, and so forth through some of the pathways that the ACA and the other recent reforms have encouraged through the consolidation of these systems and the change in payment mechanisms. But you need to be thinking about it today if you think it's going to happen in 2020, because it takes a long time to get your data in place, and your commitment needs to be early, and your leaders need to be thinking about it.
There's a lot of data. I think most health systems now are gathering the racial, ethnic, and language preference, but they're not doing anything with it to analyze and determine how to address health disparities. Bruce, can you maybe address some of that? Because many of your hospitals have patients who suffer from those gaps. How do you really address that?
Well, I actually would say every hospital has patients who suffer from those gaps. If anything, I'm more worried about those communities where we have newly emerging minority populations and we don't even know it. And I'll give you an example. So University of Mississippi Medical Center, back about 5 or 6 years ago, entered into a project I was involved with Robert Johnson Foundation to collect race, ethnicity, and language data. This was the first multi-hospital demonstration. And their initial reaction was, well, we're part of this, but we're not really sure. Everybody's black or white in Jackson. I mean, that was basically it. And, language data, ethnicity data, not sure it's that important. But they started collecting information. They found that they were registering 500 Spanish-speaking patients per month in their healthcare system. Who knew?
Right.
Where'd they come from? Katrina. These were transplants, post-Katrina, Latino transplants from New Orleans, many of whom found their way to Jackson. So until you start asking these questions and start collecting this data, and then now they've acted upon it, you don't know. And I still think many hospitals don't know this and really don't know their community even in some of these basic ways. Be there, our hospitals or any hospitals around America. And I think given what's happening with the changing demographics of this country, it's absolutely critical. I mean, when you think about population health, and the thinkers like Kindig who think about this, population health is not just the health of the community, it's the distribution of health in that community. And these inequities cut to the very heart of that. With all that said, I just want to make one other point, though.
Sure.
In addition to our being engaged in the enterprise of population health as practitioners, we also have to be engaged in it in the form of advocates, as mission-driven advocates. And I say that because all these things will help that health systems can do. But in the context, the broader social context, until we have really addressed some of these determinants as social investments, I think we'll be swimming uphill. So for instance, if we think having a secure roof over your head is important to your health, and we know it is for family security and the children's ability to go to school and be educated, and to have a very different pathway in life, then we can't have foreclosure crises in which millions of people lose their homes, which devastated large parts of our country. Massive impacts on health from something like that. So we need to be advocates for, I think, policy, not just in healthcare, but more broader socially, if we're really going to see changes in outcomes.
Right. Sure.
I want to add to what you're saying about the data, and this is such a huge issue. And what I would challenge us is to think beyond the way we understand data or we think about data in our own systems, our own electronic health record system or whatever system we're using. There are tons of opportunities to think about data beyond that. And to get to that point, we have to challenge ourselves and get us into uncomfortable environments where we're talking to people who are not the people we hang out with on a regular basis. As a department, we've been using social media data on a very regular basis in a very effective way. And the way we got there was not by talking to our own health IT informatics folks in the department. It was by going to 1871, this hub that has these entrepreneurs, these innovator people that are sitting there and spending Tuesday nights with them. This is not the group that I hang out with on a regular basis. But because we're there, we're looking at very pragmatic ways to making a difference in people's lives. People get food poisoning and they never really pick up the phone and call the health department to say, hey, I got food poisoning, can you please check out this restaurant? But a lot of people go on Twitter and tweet about it. So what we've done, we've developed an app that sifts through tens of thousands of tweets every day that are coming out of Chicago, and through machine learning identify the tweets that might be related that somebody got sick from eating out, then we automatically reach out to this individual and say, hey, we're sorry you're sick. If you answered these 4 questions, we will send an inspector to inspect that restaurant. And guess what? 90% of these people end up responding to those 4 questions. We send an inspector, inspect the restaurant, and then a day later post the result of the inspection online and go back to this person and say, hey, we hope you're feeling better. We've done our job. We've inspected this restaurant. Click here to read the result of this inspection. So as we think about data, I think there are a lot of opportunities that we could use social media data, non-conventional data, to really help drive individual behavior and hopefully have better outcome on population health.
And you're really speaking to the power of the internet and technology and what we heard about the empowered consumer. So could any of you address the dynamic tension between the empowered consumer and then the issues with the overregulation of healthcare, which dampens down the freedom of the consumer? How do we change the regulations and make things more of a market to empower consumers? Anybody?
Well, I'll start. I'll try to start. I think a lot of us have been a little disappointed by maybe the lack of response to information that's being put out there around quality. And I think it's tough to do that in the first place in any way, and it's obviously controversial. I won't get into all the weeds. But not many American consumers are reporting on surveys that they're using quality data to decide where to go. And I think part of that is I'm not sure we figured out yet how to give consumers actionable information. So the other day I went on Hospital Compare, the federal website, and I was trying to compare hospital quality in a large community. And I just got lost in thousands of measures. I couldn't, for the life of me, figure out which hospital I would, quote, want to go to, even if I got through the website. And so we've got such a long way to go. If we think that's the way to go, we haven't laid down, I think, the foundation yet for that.
So there are many problems in terms of your question. But one, in terms of this place matters, the point that David Erickson made. On the government side, and I've thought about this a little bit, we have so underfunded government, and then we've organized it in a way that's so fragmented. When you think about the way the federal government is organized in terms of the Centers for Disease Control and CMS and so forth, and then the Departments of Education and Transportation and so forth, others. Just looking at the federal government, it's very fragmented. And then at the state level, it's also fragmented. And when you have states that have such a variation in terms of their own reporting for Medicaid, and less than a majority of states actually reporting anything for Medicaid, as I understand some of the numbers.
That's true.
There are significant problems in just the basic data infrastructure from which a smart Google or a Twitter or any of these really fancy things that our first 2 speakers talked about could mine that kind of data to really create data that's granular enough for people to use. So my daughter was busy looking for houses recently, my 40-year-old daughter. And I was looking at some of the neighborhoods and so forth, and surprised that on realtor websites these days, Zillow, for example,
yes,
you can pull it up, and they'll give you all the data and so forth, and the history and the price and all that, but they also give you this quality of the schools. I'm not sure the data base that enters into that, but a key sort of issue. Why not the length of life of the neighborhood, the mortality rate for the neighborhood involved, playing off of that anecdote that was talked about in terms of making the data known. Somebody says, well, I'm going to move to the other neighborhood. I'm sure there's a more granular way for careful thinkers to talk about that data. But again, that gets to a consumer engagement around this. I thought your example about the use of Twitter in restaurants is a terrific example. We need a lot more of that thinking and a lot more of ingenuity around using that kind of data. Right. And then on the healthcare delivery side, again, I think there is a role for the personalization of like data by healthcare systems that aligns with publicly available data, geographic data, public health data, if you will, so that there can be a data bridge for cooperation between public health and healthcare delivery. There is nothing like that on the healthcare delivery side. I mean, we have most healthcare systems complaining about the burden of measurement, not thinking about the innovation in terms of trying to characterize their customer populations using some of these new data. So again, it comes back to leadership, Kathy, in terms of mental models, how you think about data, how you think about how it's going to be used, and where the opportunities are going to be to create value down the line.
You're going to add something, Don?
One thing I would say is don't use regulation as an excuse. We started an HMO, we're at 70,000 lives, and we've got care managers now helping patients navigate through things, and we're internal, so we're family, and it's okay to go to a doctor or to an administrator and say, we're having trouble getting a patient in or through your facility, and we're asking why. It's amazing the little things that are hanging us up. We're not asking, we need to go all the way into your EMR and get this piece of data. We're asking at a real high level the connections and simple things like our board chair on our medical group, we said, will you accept new patients? Yes. We can't get them in your office. What are you talking about? And we got him to sit with us at the registration desk. He had 16 rules when he could have a patient scheduled, most of them Post-it notes at the receptionist desk. He said, take them off. And it was that simple. We didn't change HIPAA. We didn't change EMR access or anything. It's amazing the little things. We did a high ED utilization project. The IT folks thought in 6 months we'd have a program written to flag these people. We came up with a paper way of doing it. And there were patients who were coming to our ER 100 times a year. Horrible care, horrible quality of life, and literally in a couple of weeks had that completely turned around. So don't use it as an excuse.
Right. I've always liked the don't ask forgiveness rather than permission. Just forge ahead. Yes.
You know, I want to go back to the idea of the informed consumer, and I think the concept that the informed consumer or the tools that the informed consumer is going to need to be more informed is way down the line. I just have a problem with that. I think it's a lot closer than what we think. And I think just the way that I've seen the way the data has been playing over the last just 3 to 4 years, I think it's accelerating so quickly. I mean, I remember when back in 2011, when we started liberating the data that we have at the health department, everybody was like, what are you doing? What is this? Why you're doing this? Nobody's going to care about this. I remember when we liberated all of our restaurant inspection reports online, I had a reporter, he's like, so what do you want me to do with this spreadsheet that you put online? Well, what turned out that maybe that reporter didn't know what to do with that spreadsheet, but a bunch of people who do a lot of data mining knew exactly how to visualize a lot of data sets, how to put data sets on top of each other and overlaying them and put them in a geocoded map that you could look at online. I would encourage you to check out chicagohealthatlas.org, where we've put all kind of data sets online, and we had this random group of people who came in and said, we'll visualize these data sets for you. And now you can go, a lot of what Zillow would look at is looking at life expectancy, looking at lead poisoning, looking at diabetes rate, looking at cardiovascular mortality rate and morbidity rate, and neighborhood by neighborhood in our city, and give you that visualization. The informed consumer process is not going to happen from the healthcare delivery side. Right. It's going to happen from the technology and innovation side. They're going to mine into these data sets, these algorithms are going to put them for us, and they will inform the consumer. And very soon, the way I'm going to choose my primary care doc is going to be very close to the way I choose whether I want to buy a Honda Civic or a Mercedes. I mean, I need more information before I choose who's my doctor going to be. Right. And I think this is happening a lot sooner than what we think.
Like TripAdvisor for healthcare. And we have other groups, like the Leapfrog group does a patient safety score, which I found very helpful, where you can go in and get an A through F score. But at least it's one data element. You have to look at multiple things. You don't read the one review on TripAdvisor and say, I'm not going there. You get the general gist. So, okay, let's have a few questions from the audience while we have all these experts here.
Hi, I'm Laura Oppel from the Michigan Health and Hospital Association, and I read an interesting tweet today about an article in the Harvard Business Review, is it time to focus on copying people rather than innovating? And is it, are there so many nice, wonderful programs out there that instead of sending everybody out to innovate 9 new things, should you look to what is being successful and do more of that in healthcare rather than this complete focus on innovation? And I just throw that out to the panel. I haven't read the article. I just read the tweet.
That's definitely the way to do it.
Yes. 140 characters. We got it. Okay.
I was going to answer in 140 characters.
There you go.
Kind of my philosophy at the health department, when we talk, our team, our leadership team at the department, when we talk about this, we talk about 2 important aspects of our work. We want to make sure that we have sound management within the department, but we also want to make sure that we're doing disruptive innovation. And it's the balance between these 2 that really drives things forward. So I do want us to be always trying a lot of disruptive innovations, and I'm hoping that the majority of them will fail so that some will succeed. But on the sound management side, this is where we need to identify practices that we know are good, there's evidence behind them, they work, and really take them and incorporate them. So I think it's not either or, I think it's both. And honestly, it depends on the leadership style, depends on the organization, depends on the sector that you're in, and how much more you need to do of each part of those. But I think, in my mind, a good, solid organization is an organization that does sound management, but also be nonstop doing disruptive innovation.
We still need innovation. And let me give you an example. Think about what Google's doing around self-driving cars. And they're spending billions on that. Marry that to Uber, that model, and imagine what you'll wind up with probably in about 10 years in America in terms of how you'll get around an American city by basically with your phone summoning a car without a driver to take you somewhere more safely than if it had a driver in it. This is not science fiction. We're on the brink of seeing this. And there are 2 states now who are licensed provisionally driverless automobiles for testing. I think it's Nevada and California. Healthcare is still pretty recognizable to what it was 50, 60, 100 years ago. So I think we've got a long ways to go in terms of real disruptive innovation. Certainly there are things out there that need to be brought to scale that we know work and we often forget about or we don't do because we can't align. But I think we've got huge upside potential, and I've just started to see the beginning of innovation in healthcare.
I think it's a good point, though, that the Twitter you made, that innovation is important, but there are basic standardized protocols that we have not mastered in healthcare. So there's that challenge as well.
Well, I think it depends on how you define innovation. This is a pretty tradition-bound, sort of field that we're in. If you look at the educational, and if you look at the attitudes of us leaders, slow to change. A lot of innovation may be taking an idea down the hallway and applying it in a new way. So that's one comment I'd make. And secondly, the performance characteristics of the healthcare system are abysmal if you look at the outcomes relative for the investment. And I think people have been over that. So that demands that we do something different, which, again, if you broadly define innovation, might be applying some of those other ideas from down the hall. So we ought to read the full article maybe and figure out what they're actually talking about, and then we'll know whether we're answering the question right.
But we're an expert panel, so we can comment on anything. Yes, okay, we have time maybe for one more question. Interesting.
Janet Corrigan, I found the sort of series of discussions this afternoon very interesting, and I feel a little bit torn because earlier this afternoon we heard a lot about market-driven kinds of approaches, engaging consumers, competition, getting us to better health care as a result. And then most recently we had the sessions that really called for more of a community collaborative approach. So on the first, you've essentially got national companies, competition, market-driven kinds of innovation and change within healthcare. On the second, though, to address all the social determinants, it's more down at the local level, and it's a collaborative approach with strong government kinds of input, I think. It seems to me that the provider payment programs that you want to drive improvement in one area versus the other are different. In the first case, I mean, maybe having ACOs and bundled payment programs, we heard about bundled payment, could be very helpful, but to really address the integration with the social determinants of building healthy communities, you'd almost like to see a regional budgeting approach that integrates healthcare and social services. I don't know if others feel the same way, but how do we balance this competition to achieve certain things versus collaboration that's required to achieve others, especially in the healthy community area?
Great question.
I don't think it's an either or.
Yeah.
I think it's a both and. I think our political parties would like you to think that way. They'd like you to think along the dimension of a community-focused, publicly funded approach versus a private market kind of approach. And I think a lot of our political rhetoric and a lot of the funding that goes into our political parties tends to try to shape our ideas around that. But I think it's much more complicated than that. Because I fail to understand how you can't have all of those approaches working well at the same time, quite frankly. So again, your comment earlier about a market driving some of this change at the granular level, I think it does too. I agree. But I also think community-focused approaches like we have in Minnesota, like you pointed out, are critically important. I think that the performance at every one of those levels is actually important to the result of actually taking that 17.3% or whatever it is of GDP and getting a better return out of it, or getting a reclassification of some of that addresses the Bradley sort of problem with respect to the distribution of social investment versus healthcare investment. So that's the way I look at it.
And I don't think we can even afford not have both of those working together. We really
Exactly.
can't. And even if you take, tobacco, for example, while we do need, hospital systems and plans to push for people to quit smoking, you need the government to really do its work when it comes to, policy systems and environmental changes to make it less attractive to smoke. I mean, I'm very excited about all the plans in Chicago that cover smoking cessation efforts, but I'm equally as excited every time we raise cigarette tax. We have the highest cigarette tax in the nation, and for many of you it might be a sticker shock. Every pack of cigarette in Chicago is taxed with a combined tax of $7.17 a pack. But if we don't do that, you're going to continue to have a problem. So we cannot afford not having both of those working together.
I think we saw a recent example with Ebola. Yeah. We don't have an Ebola vaccine because there was no market for an Ebola vaccine or paying market for Ebola vaccine, at least until recently. And that's market failure. So markets can do incredibly innovative things, but they are not going to do things for which there's no return. And they're not by themselves going to eliminate inequities. That's not why markets generally function. So there has to be a role for both the market as well as for government to step in, or else we find ourselves in the situation we are now, where technically Ebola vaccine probably not that hard to have, but nobody's willing to make the investment because the folks who got Ebola weren't paying a lot of money for the vaccine.
So it gets back to that partnership and working together. So I hope today in this panel has been an opportunity for everybody to think creatively and think of opportunities to partner so we can improve health. So please join me in thanking our expert panel.